This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct specialty care has allowed me to spend more time with my patients, which is key to being the best doctor I can be, and that brings me incredible joy. It has allowed me freedom from administrators, partner meetings, and most insurance headaches. Not all, but most. It allows me work-life balance and offers my patients affordable, reasonably priced care. I'm Dr. Scholl of GastroDirect, North Carolina, and this is my DPC story.
Dr. Shannon Scholl graduated summa cum laude from North Carolina State and earned her medical doctorate and master's in public health from UNC at Chapel Hill while raising her 2 girls. She was in an area private practice for 14 years, but became unhappy with the traditional way of providing medical care, which puts an emphasis on numbers rather than people. When her daughter became ill, she took a hiatus and decided to explore other ways of delivering care. She enjoys getting to know patients as individuals and has had the privilege of caring for generations of patients within many families, the highest imaginable praise. In addition to the Western medicine in which she trained at UNC, Dr. Scholl is well-versed in data-supported functional GI medicine, including leaky gut. She is also proud to be the Plant Fed Gut Masterclass certified. Welcome to the podcast, Dr. Scholl.
Thank you. Nice to be here. Thanks so much for having me.
It's such a treat to have a gastroenterologist talking about direct care on this podcast because, as we know, there are so many people in specialty care who are exploring the world of direct primary care as a business model and saying, hey, I can adapt that to my practice as well as a fill-in-the-blank specialist. So when we talk about story and we talk about how story convinces other people, hey, their story is very similar to mine, I want to open with pulling from the fact that you are a doctor and a mother. And what I had read was that during the time where you were going between your old way of practicing and your new way of practicing, there was a time where your daughter was ill and she needed you. And so a quote that I had pulled up in my mind when I read that was, know what matters most to you and be unwilling to compromise those priorities at almost any price, from Frank Sonnenberg. So can you open our interview with, how did you go from your fee-for-service job and having already raised 2 girls, even before residency, to a direct specialty care doctor and still being able to take care of your girls in a better way?
Yeah, that episode with my daughter informed what I'm doing now in a couple of different ways. So before I made the pivot, I was on the golden hamster wheel. I was in a really successful practice. I was really popular in my area, very much in demand. I had 6 to 8 week waits, which actually drove me crazy. I did not like that. My partners thought that was great. It was job security, but I felt so guilty about it. And I would go into rooms and patients would say, I'm feeling better, but it took so long to get this appointment that I didn't want to give it up. And I was like, what's the point? I mean, what's the point if they have to wait so long that they get better just by regressing to the mean? What am I doing here? And so I lengthened my hours. I started going in at 7:30 instead of 9. I worked through lunch. I stayed until 6:30. And I saw 30 patients a day often. And I just got so burned out. And I never felt like I was doing a good job. Patients liked me. They were vocal about that. But how it is. You walk into a room and does this person have Crohn's or ulcerative colitis? I can't quite remember. I got to check the chart really quick. And I just didn't feel like I knew people well enough and I was doing a good enough job. So anyway, my daughter got really, really sick. She was admitted to the hospital. She ended up being there for 3 months, but I didn't know it at the time. I just knew that she was really sick. And I was going through some other life changes and just decided something's got to give. And so I left the big practice. I left very suddenly and I focused on my daughter. And during the time that she was in the hospital, she was not getting better. And I'm a doctor and I have some hospital experience, and I have an MPH. I'm familiar with the data. I'm capable of doing lit searches and stuff. And I was trying to talk to the doctors about, what might be going on with her. And I was getting dismissed. And I had the impression that they didn't know my daughter very well. And I found that really maddening. That sort of acted as a storm or a crucible for me to find a different way and a better way to practice medicine. And so I was talking to a friend of mine who's a DPC doctor. We were at brunch, and in her devious little way, she said, have you ever thought about doing it differently? Not having a boss, not getting right back on that golden hamster wheel. And I just started looking into it, and it informed my practice. Now, as you know, when you do DPC, you have a lot more time to spend with patients. And that experience of being dismissed by healthcare professionals really informed how I approach my patients. I have plenty of time with them, and I enjoy that aspect of it very much. It's not, when I was doing traditional medicine, I felt rushed. And in my mind, there was always a clock ticking. And it was always trying to get the patient to tell their story and then get my story out and educate as much as I could. And then you're on to the next room. Very unsatisfying. Now, I feel like I can take as much time as we need. And I just love it. It feels so much better.
And as it should be, it's like we were talking a little bit before we started recording about how what we went to medical school for is really incongruent with what we see on the floors in our jobs after residency. And when you talk about how like there's a time clock in your head and about like getting a little bit of the patient's story, at least I had read this, it was an ICU. I think it was a nephrologist who worked in the ICU. Their post was talking about how they have their workflow of how they make it through 40 patients in a day. And it was like, number 1, number 2, number 3, number 4. And then it was like number 5. It wasn't number 1. It was like number 5 or down further in the list. It was like, and have one sentence about the patient. This is the humanism in medicine. Number 6, blah, blah, blah. And I was like, oh, I just shook my head because, and I get it. It works for some people. And maybe, that was the short version in the LinkedIn post that I had read. However, that idea that there is an algorithm and you can only have one sentence to know your patient is how you get through 40 patients in a day. I am empathizing over here because your daughter being in the hospital for 3 months, my father was in the hospital ICU for 22 days before he went into hospice. And the same feelings of, I actually can talk with you about differentials and about how his progress has been, culturally, what's going on. I'm sure the same things happen with you being the mother of your daughter. And it is really, really a disservice to our patients when we're not able to spend the time to talk with them. And it really hurts even more when we ourselves are patients or our family members are patients or people we love. So when you had this talk over, and I love that this is how you found out about the direct primary care business model, because everyone has their story of how they learned about it. But when it's fed to somebody, after an event like what had happened to your daughter has happened, it's perceived differently because there's some people who will hear about DBC and they will not really act on it. They won't actively think about it. What happened in your head after you heard about that? You started doing the research. What were the next steps that you took towards opening your direct specialty care practice?
I think I was kind of naive, but I'm grateful for that. Because like anything, I mean, a journey of 1,000 steps begins with one step, right? Or whatever that saying is. And when you get to the end of the journey and you look back and you see how far you've come, it's like, wow, I had no idea what, I was getting started, but I had daydreamed for a long time about getting away from insurance, sitting there on hold for the peer-to-peer. Many, many, many times I had fantasized about just not having to deal with this stuff. And I had this naive belief that because I thought I did a good job, I do think I do a good job. And because I had a good following in the area, that I would be able to just say, hey guys, this is where I am, come on and see me. It turns out I was right. It just took a little longer than I thought it would. So the first thing I did was, I guess I went home and built a website. I used Squarespace and I built a website. And I think there are two kinds of people in the world. There are the ones who aim and aim and aim until they're sure they've got the target dead to rights, and then they fire. And then there are people like me who just start firing and eventually correct their aim until they're on target. I didn't even have a scope contract. I had set a soft date of January, and then it turned into February to open. And I finally decided May 6th is the date that I'm going to do it. And I put that on my website and everything. And then as the deadline approached, I was like, I'm really going to figure this out. And I did. I made it happen. I found a place because I was thinking, you know what, if I open May 6th and all I'm doing is telemedicine from my living room, fine. These are probably going to be people who, I have reviews in the area. So I felt like I had a little bit of a runway, but I pulled it off. I got a place to rent and all the supplies. Amazon is great for that. And I got a scope contract in place by the time it was time to scope my first patient.
That's incredible. And because, as it's mentioned on your website, you are opted out of insurances, period. How did you end up getting to negotiate a scope contract? And how do you make scopes affordable for your patients? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Yeah, this is a really important part for specialists. That was the hardest part to figure out. And what I ended up doing is I approached an entrepreneurial group, GI group in my town, and I negotiated with them. What I did is I asked them what they get paid, their bundled price for minus the professional fee for a Medicare patient. And they told me, and I said, well, I'll just pay you that. And then I just tacked my professional fee on top of that. And actually, I guess you can't separate the professional. It's just a bundled price that they get. Anyway, so at the end of the month, they bill me for the number of scopes that I did, and I've already collected from the patient. So when I schedule them for the procedure, I just charge them, and then we do it at a fully accredited ASC, and then I pay the scope center after the fact. And, they're looking for volume. If they have rooms that are empty, then volume is good for them. And what I said to them is, I will bring you volume. You don't have to do anything. You don't have to call the patients. You don't have to see them. Nothing. I just show up, I scope them, and I pay you. And that's it. And they were very happy with that arrangement.
That's awesome. And let me ask you there, because previously when I was doing scopes, like I had one patient who she went in because her insurance covered a screening colonoscopy. And then after a polyp was removed, it was a diagnostic colonoscopy, and ding, 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 there's a $7,000 bill. How do you work it so that the patient is paying you the bundled price plus being able to use their insurance or afford, something that turns from a preventative to a diagnostic scope?
I have those conversations with people all the time. And the way that I kind of approach it is a part of what I'm doing is educating the local public, right? Because not everyone knows about this trend. And so when people call me, my thing is I just act like a good person. I act like I want my mechanic to act when I go in and I don't know anything, or my HVAC guy or whatever. I want them to be honest with me, even if it's to their detriment. I want them to tell me the truth. So that's how I approach it with patients. So I tell them, I get all their information. Are we doing a screening? If that's the case, then you are granted a free colonoscopy every 10 years. And here's the gotcha. If they find a polyp, and then when you wake up, it was a diagnostic procedure now, and that's going to go toward your deductible. You have to pay through your deductible until you've met it. And then your insurance will kick in at 70 or 80% or whatever. And I tell them, I've got a pretty good adenoma detection rate. So if you get it with me, it's about a 50% chance that I'm going to find a polyp and take it out. And my scope price is $1,500, whereas altogether bundled, whereas in my market, it's $2,500 to $4,000. So, it would be nice to have a crystal ball in moments like this. I don't know whether you have polyps or not, but there's a decent chance that you do. And it's going to be a lot less if you get it through me. Usually, I think too, people just respond to authenticity. And usually, $1,500 is not a big buy in this market. It's not small, and everybody's different, but they're usually surprised that that's all it is. And most of the time after we've talked for a bit, they want to have it with me. There is, in DPC, we talk a lot about the cost, the healthcare costs to patients, but the quality is really important too. It's higher quality care. So I haven't
absolutely.
Hasn't been that much of a barrier. Plus I believe in what I'm doing, because I don't know if you read this on my website, but I grew up working class. My mom was a nurse and my dad worked for Bell South. And, they had 3 kids and they worked a lot of overtime. And my dad was always screaming about the squirrels getting into the damn attic and turning off those lights and all that stuff. And he thought the doctors were crooks and, never took the dog to the vet. And so I grew up with that ethos. And so when I'm talking to patients, I've always felt this tension between doing what's right for them and and being a good shepherd of their healthcare dollars. So I just can't help but tell the truth. And that they usually really appreciate that honesty, because this is all an education for them. They had no idea that they would go to sleep as a screening and potentially wake up as a diagnostic with a huge bill.
It's so important. And, I think that as we've seen through the pandemic, when people don't have access to a doctor who has a relationship with them and who knows them, it really makes a difference culturally. We see the number one doctor in the country is Dr. Google. And we see, patients who I had a patient who she literally described that, she sees me for her actual care, but she had to go in for her Medicare physical. And she described the visit that she timed was less than 8 minutes, where the doctor was literally inching his way back towards the door, handle on the door. And she was like, I had lots to say because, I had some questions, but that wasn't part of the Medicare physical. And I joked, I'm like, oh, you mean the one where you're not supposed to listen or touch the patient? Yeah, that's a great physical. So, this is where, the DPC model really embodies old school medicine. And one more question there, because, as you mentioned, your dad's ethos when it came to doctors and how we're really bringing relationship-based medicine back to our patients. What is it like after the colonoscopy or after the endoscopy? Because that is something where when I was doing procedures, I would, go out to the waiting room, find the partner, the parent, whoever it was, and tell them this is what we found. I would draw them a picture, yada, yada, yada. That is definitely not the standard of care in our area. So when you went from fee-for-service to being able to bundle and transparently talk about pricing and do procedures for your patients, what does it look like after you're done with the procedure?
I always, but I'll be honest, I just don't have it in me to blurt at somebody while I know they're too drugged up to understand. So I have always given them plenty of time to wake up. And my nurse no, this has changed. So you know how this is now, instead of being part of a big group and you don't know what's happening, you can't really get your hands around all the pieces of this big operation. It's just me and my nurse. And so my nurse is actually working in post-op at my endoscopy center. part-time until we're full-time. So she works up there. So we have continuity of care for our patients. So they wake up and they see Lacey, and I let them wake up and I talk to them. And then Lacey calls them later that night or texts them, because we text like all DPC, most DPC docs do, or DSC. And so I've never said it that way, but relationship-based is exactly what we do.
It definitely is. And I think it's important, for people to hear your story, because you're making an impression on people who are going to be future gastroenterologists and future gastroenterologists choosing direct specialty care. My husband, who was also doing scopes as a family medicine doctor, that's what we saw in Nebraska. It's like, that's part of the care. You do the scope, the patient, wakes up and you go talk to them and their family, you answer the questions, and then you check on them later that evening. That's how you do it. It's not done any other way. And so I really think it's important for, as you go into the future, that this is how you and Lacey work with your patients who because this is what also your patients will be talking about when they spread, the story of going to Dr. Scholl as their gastroenterologist, right? So I think it was really impactful all around. And when we talk about procedures, in terms of, you mentioned how, it took a little bit more time, but people eventually found you. How did you end up, opening, you got your website? How did people end up finding you?
It turns out that it's mostly through Google searching. So I had to make sure that I was using my name as one of my keywords on my website. And then, it's probably worth hiring someone who knows such things, because I had a friend who helped me. You need to say certain things on the front page of your website to help people to find you, to get up to the top of the Google search. So I did those things. And I was lucky enough to get on a couple of mommy boards on Facebook. I had been there in my old practice, and that's just, I think, luck. People just said they liked me. And so when I came back, I announced that on the mommy boards, hey, I'm back, and I'm taking new patients and I'd love to see you. That was really important. And, for gastroenterologists, for specialists in general, I think it's also really important to market yourself on LinkedIn, but your audience needs to be insurance brokers who are brokering contracts for self-insured employers, because the market is aware of this DPC, DSC trend, and they are looking for bundled procedures at reasonable costs. They're looking for knees, they're looking for cardiac caths, they're looking for colonoscopies. They're looking for anything that has a CPT code. They're looking for a cash pay price that is about, one insurance broker told me, I think it was 1.7 times Medicare allowable is like the golden number. And Marielle, I want to go back and just say one more thing, because you reminded me that I'm talking to future gastroenterologists. There is that hump of convincing someone who has insurance that they do want to pay cash for you. And so I lay awake at night trying to figure out how to make my business more profitable. And the latest thing that I have entered into is a contract with my endoscopy center to be an employee of theirs. So I am not opted in with any insurance companies, but I don't have to be. They can use their tax identification number to file the patient's insurance. And that makes it sort of a hybrid model, but I'm not saddled with any of the administrative burden of dealing with the insurance. I still see the patient in my office for a cash fee. We schedule them with the endoscopy center. The endoscopy center on the back end bills their insurance, and that's all their administrative people. I don't have to do any of it. And the patient is happy because they were able to use their insurance.
Absolutely. And I hope that people who are specialists listening to this podcast are really thinking about that. In terms of primary care, that happens very frequently where we'll say, like, you can pay $2.62 for X lab, or you can choose to use your insurance. And then if you choose to use your insurance, Quest will bill you, LabCorp will bill you, they'll bill your insurance. But for our services as a doctor, this is where you're getting relationship-based care, in exchange for payment. So I think that that's really a great point that you're highlighting, because when it comes to primary care, we're doing 80 to 95% of everyday things. But when it comes to procedural care, when it comes to specialty care that are not really thought of as oh, I could choose insurance or cash pay. You're bringing that part into the conversation, which is so important. It gives, when we talk about your dad again, it's like, this is a way to give a patient transparency as well as an option. And that is one thing that I feel more medical students and residents need to know about is you have the option of direct specialty care, direct primary care, and that this is a way that you have just educated the audience who are potentially dreaming about being gastroenterologists or already gastroenterologists. So awesome. So when you made this transition, and you've already mentioned ways that your practice, your way of practicing, your art of medicine has changed. One note on your website that I absolutely loved was, we limit our practice size, not our care. So when you think about that copy on your website and you think about how you talk to your patients and how you treat your patients differently on the clinical side, how do you act differently as a doctor now in your practice?
Nothing has changed about what I want to do and the kind of medicine that I want to deliver. I just am able to do it. I don't have to ask anyone permission. If Lacey and I decide that something isn't working or we need to change up what we're doing, we just decide and then we try it. I spend plenty of time with people. I mean, I schedule people for an hour. A new patient is an hour. And I'll tell you one thing that changed that has made all the difference in the world. I can talk to patients about their diet now. And it's this weird thing that GI fellows we're not taught nutrition. I remember I was given a binder and I had a 3-month self-study block. There was no tests or anything. I was just given this really dry binder with like a page that said zinc and all the things it does in the body or what a deficiency looks like. And I didn't learn anything. It's never made any sense to me that we're supposed to not talk about what goes in top, and we are supposed to think about what goes on in the middle and what comes out the end. It doesn't make any sense. So during that hour, I talk to people about, what they're eating. I talk to them about their microbiome and how they need to support it, because the microbiome is now considered an organ. It elaborates hormones and creates neurotransmitters. And serotonin and dopamine are made in the gut. Most of it is made in the gut. So it's really important that people are feeding that organ correctly. And I never had time to do that in my old practice. Never. So I like to say I nerd out all over people. And I love that. I mean, it's an area of interest for me. So I get to indulge my passion and stay up on the latest science in an area that I'm really passionate about. And patients hopefully benefit from that. And we have time to do it.
It's so cool. And when you were talking about how, previously you were like, oh, wait, does this person have ulcerative colitis or Crohn's? How are your notes different now that you don't have to, in 72 hours, finish your note for the insurance company?
They're narrative. They're free text and they're narrative. There's none of that. I don't even know what you call it, but the macros, where you click the endorses or denies thing. I mean, it's all just a bunch of generic text. It doesn't convey any real meaning or any hint of what the person is like, or now it's all narrative. And I don't know, that sticks in my brain better. And I don't know, get into the person's, I don't know. It gets me not into their head, but it helps me to empathize. I understand what they're going through. I'm writing the story of their life or their symptoms or whatever. Much better.
I find that when, people like yourself are sharing their stories, emotion comes with it. And then I connect emotionally with people whose story I hear. And so I definitely understand that. I mean, when I was a resident, that's how we were taught to write notes. Like, handwriting notes was actually a thing. Like, you and I remember that, but it's so funny when I talk to residents, they're like, I can't function. There's no power in the hospital. We don't have any EMR. It's like, there's a pen and paper. You can do it. But yeah, we were taught to, when we're doing notes, when we're doing, especially on wards, especially in the ER, that you write so that if someone's picking up your note, they understand what your thoughts were and what your plan was. And I think that in DPC, I mean, I totally empathize with you sharing about how your notes are more narrative, because we are working for our patients. We are not working for magic codes and, how many points can we rack up in a day? We are working to maintain the health of our patients. And so when it comes to how you mentioned, you nerd out and you use that MPH brain of yours and that MD brain of yours to treat your patients, what happens if a patient says something to you and you're like, oh, I don't know the answer to that. I would like to look that up. How does that work out in your practice? Are your patients then scheduled for a follow-up visit? Is there a membership option? How does it work when patients have multiple visits in your clinic?
I haven't figured out a way to do subscriptions yet because it's different in specialty care. Ideally, they come to me with a GI problem. We spend some time together, which is maybe 2 or 3 visits, and figure it out and fix them. And that's the idea. And I'm toying with the idea of doing a subscription service for IBD patients because they do have a chronic illness that they're going to need to come back and see me for. I'm toying with it. Just haven't figured it out yet.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. But you can figure it out and you can change and pivot if it doesn't work out for you, just like you did on your opening day. So it is amazing. It is so freeing. When we talk about this idea that you are toying around with the future, would you have subscriptions or not in your practice? Can you summarize for the audience, how does it work if a patient finds your website or finds Dr. Scholl and wants to become a patient at your practice? What are the ways that they pay you?
Sure. Well, so one of the great things about my practice, I think, so we really took direct care literally. So I carry around a cell phone. That's the first thing. I have a cell phone. If I'm busy doing something, I forward it to my nurse or she carries it around. So when they call, they get a human being. They get one of us, one of the 2 people who know them and can get into their chart and answer their question. And if we don't pick up, we call back. I mean, if you call my practice and I miss your call, I call you back. You don't even have to leave a voicemail. If you called me, I want to talk to you. But when they call and they get me, they're always so surprised. And it's usually, oh my gosh, I'm so sorry. I don't know how I got this number. I didn't mean to call your personal phone. And I'm like, no, it's okay. It's GastroDirect. You get to speak directly to the doctor. How can I help you? And that just floors people. They're so amazed by that. But we also tried to make it very consumer facing. So I used to get complaints all the time at my old practice. People would say, I've called 6 times and nobody's calling me back. And I couldn't figure out where it was going wrong. And I know how frustrating that is. You've got something on your to-do list and you want to get it done. So I have a button on my website that you click to enroll, and it takes you right to my EMR and you build your own chart. And once you hit submit, you show up in my electronic medical record and we text you or we call you or sometimes we email you to set you up for an appointment. I do also sometimes I have the option for a discovery call if people want to call me and just kind of see if we're a good fit. And it's free. It's 15 minutes. And to be quite honest, I do it if you schedule it and talk to me, or if you just cold call me. It's essentially the same thing, but this is a more structured way of just letting people know, hey, I'm willing to talk to you for 15 minutes and figure out if you like me and if I have the skill set that you need.
I think it's super important. And on your website, just, for the audience to know, you can go on Dr. Scholl's website and you can actually, as a patient, pick the time that you want the meet and greet. You have the acuity scheduler up there. And, like my practice, we have on our Google site, and I don't know if yours is like this, but you can link your scheduling calendar for your meet and greets to your Google business site. And it's just screaming, this is a place of accessibility, so it's something that absolutely is not culturally normal in our society. I mean, we are making it more normal, but it is definitely not something. So people are like, I'm laughing so hard when you say that people are like, oh my God, I am talking to the doctor, because even as a direct primary care doctor, when I had called my endodontist and I got her, I was like, oh, I'm so sorry to bother you. I'm like, what the heck? Because culturally, that's just not how we operate in America. So I just love that, you are shocking your patients in a great way with accessibility and answering the phone and talking to them, or, engaging with them one-on-one. So I love that. Now, you talk about how patients do the meet and greet. Can you tell us, how do you manage the meet and greet so it's limited to 15 minutes? And what are some of the things that you talk about with each patient during the meet and greet?
What I want to know from them is kind of, what they're struggling with and what their goals are out of my care, what their frustrations have been. It's so funny, Marielle. Whenever I talk to other doctors about how, patients can call and they can get me immediately, they're like, how do you do that? Because they just assume that patients are going to be calling you constantly and driving you nuts. It's funny when you give them permission, when you give freely, never feel like, okay, you're taking advantage here. Almost never. And so it's not hard to keep people to 15 minutes. They're almost trying to get off the phone too soon. I'm always like, it's okay. It's all right. But yeah, I just want to know what they're struggling with. And I want to be able to I want to make sure they understand the practice model, because I don't want them signing up, enrolling in the practice and then having a nasty surprise. But yeah, it's just what it sounds like. It's a meet and greet. It's, hi, this is me and this is what I'm about. And who are you and what are you looking for?
Awesome. And in your practice, do you accept patients acutely for care? Like if somebody is having, 3 months of bleeding and like, I think of the well male, probably early 20s, that their wife made them come into the clinic, and finally, it was the wife who sat there and told the story of the husband. And this patient in particular had turned out to have ulcerative colitis. So I ask this question because in my practice, that's one thing that I will not do unless it's a very rare circumstance, where I will not take an acutely, a patient in acute needs. Like if somebody has a diagnosis of cancer and they need, to have a connection to, they need a referral, or if somebody has like an immune issue where their insurance dropped them, so they can't go to their previous clinic, and I can help by getting them referral to the new clinic. Like that's the type of acute visit that I will typically take on. But when it comes to people who are like, my person, is diagnosed with this acute issue, and we want you because you do home visits. I have found in my practice that people who join like that don't understand the model. And so for me as a subscription-based doctor, it's different than your practice that doesn't necessarily have subscriptions. So that's where I ask the question, do you take acute patients, or do you take patients with acute needs, and how do you handle them if you do?
I do. I'm often sorry when I do, for exactly that reason. And in fact, I'll do you one better. The patient who calls and has to be seen immediately, and then I make time. I do a telehealth or something that day. I'm almost always sorry because it hasn't been well thought through, and I'm not sure what the ingredients are there, but on their part. But I find that it's usually not the best relationship.
That's it. I think that you hit it on the head. It's not the relationship that they're looking for. It's the desperate need for care and access. And while we provide that, what's driving us continuously going into the future is relationship-based care. So, it's something for people to think about when they're, thinking about, I will take anyone who comes in the door, and then versus I do have the ability to practice autonomously and say who I can and cannot accept in the practice. And that does not mean cherry picking, but it means, making sure that you're sticking to your guardrails, boundaries, so that you can thrive as a doctor. I mean, when you talk about seeing 30 patients in a day and constantly working, going in earlier, what kind of care is that to you? And if there's no you can't serve any of your patients. So
although I do think that you can turn that on its head and get creative with the model if it's something that you want to do. For instance, I heard a story somewhere about a young plumber, and the area he was in was saturated with plumbers. And so instead of trying to compete with that, he only worked at nights and weekends. All the other guys worked during the day. He was only a nights and weekends plumber, and he killed it. And he was happy. There was a time in my practice where I thought about doing urgent GI care because I thought, trying to get this thing going. And I thought there's a 6, 8 week wait everywhere in my area. And there is this acute care need. So maybe I want to do that. I ultimately decided not to for the reasons we're talking about. But, for an entrepreneurial person who likes that kind of urgent, acute stuff, I mean, there's definitely in my market, there's room for it for sure.
And you do bring up a good point. As you're mentioning that example, I think about Dr. Lisa Davidson, who spoke about how when she's on vacation, there is like an urgent care after hours concierge practice who will cover for her patients and other DPC doctors in the Denver area. So I am glad that you mentioned that point. It's this is why I think, hearing everyone's perspective is so helpful. So it's going to probably be a challenge to someone out there who might love the acute situation care. So awesome. Now, in terms of the growth of your practice, even though you don't have subscriptions, your practice grew insanely well. So can you share about your growth and how did you and Lacey bring all of these people on and get them care as, quote unquote, beating the standard of care in your area in terms of that wait time?
I do not know how it happened. I'm still amazed by it, but Lacey showed me a chart the other day of our growth, and it's been like this. We're like 20% quarter over quarter. And we do 1 clinic day a week. We now need 2. And my goal for my career actually is I want to do 2 clinic days and 2 scoping days. And I want to have 3 days at the beach. That's my goal. And then I'm developing, we can talk about that later, but I'm developing this online course too that I can do from anywhere. But yeah, I don't know. I mean, I like to think that I take care of mostly women. It's not all women, but I co-founded a women's center for GI health 10, 12 years, something like that ago. And it was really, really popular. And that just happened naturally. 95% of my practice just naturally became women. And so when I started this practice, actually, I started it as women's gastro. And I decided to rebrand because I was having to explain all the time that, yes, I do see men also. It's just, and we were funny about it. You've got to wear a wig and Man Day Monday and all that stuff. But ultimately, I decided that I needed to change the name to communicate the model. And I also needed to not scare men off because, I was trying to build a business. So we did that. But I don't know how we grew. I like to think that women talk and they tell their girlfriends and they tell 2 friends and they tell 2 friends. And then, here we are. I don't know. I think that getting reviews is really important. Google reviews. That seems to be really important for the algorithm and just people pay attention to those.
They truly do. They truly do. Consistently since probably, I don't know, maybe around month 6 up until now, the number 1 lead on my website is Google. And so it really does make a difference. Dr. Dipti Munkor was the one who told me, don't take it for granted. Google really makes a difference. And she absolutely was right. When we talk about branding, I am glad that you mentioned how you switched in terms of this is a business. You were making your appeal with GastroDirect more broad rather than only to women. So do you have any other tips for people when they're creating their business from the ground up? They have no previous, direct specialty care, direct primary care name. How would you approach branding if you could have gone back?
I think I would have approached social media earlier. I'm doing that a lot now. And I tried to do it myself. I took some coaching classes on it and it just was too stressful. There's too much to do. So I hired a young woman who's very facile with all of that stuff. And I think that has helped a lot. I get, a few new followers a week. And I think that has potential to explode eventually if you're offering, relevant content. Well, I'll tell you things that did not work that I tried. Advertising on the radio was incredibly expensive and it did not help a bit. I got 1 referral. I think I spent $13,000 and I got 1 referral.
Yeah, it's painful when that happens, but I'm glad that social media has really kicked it up a notch for you and 20% growth each quarter is flipping amazing. I will say that your social media is on point. So kudos to you and your social media person. I mean, you did one where you're talking about your course, which we will absolutely get to, but you're talking about IBS has 10 reasons and you're like going 1 through 2 and then 10. And then it's like, digestible, super informative. It's engaging, educational, and entertaining. So I totally think you guys are on point when it comes to social media. So as you continue to grow your practice and as you work towards that goal of 3 days at the beach minimally, and then everything else comes after that, how would you know if your practice is full without subscription members?
I think if it gets to feeling the way that it did in my old practice, where I don't have a handle on things, and I'm not a super control freak. So that could, but when I feel like I'm losing that relationship, when it feels like that, I'm probably going to hire a nurse practitioner. That's what I think I'm going to do, because I want to build this out more. I want it to be bigger than just me, but I don't want it to be so big that people feel like a number. And I think you have to pick the right people, because I think culture in a DPC or a DSC practice is really important. How many times have you heard people say that, they really like the doctor, but they hate the office, and they don't want to go back there. Your office needs to be a place where it should be like Cheers. You remember that old show? You walk in and everybody says, Norm, it should be like that. And that is how our practice is. So you have to choose your people carefully. Lacey is a gem. I lucked out. I got her drunk. That's how she got the job. I took her to dinner and I said, we knew each other from my old practice. And she'd always been a superstar, super smart, great critical thinker, just sweetie pie. And I took her to dinner and I said, I'm thinking about doing this. And after her second glass of wine, she said yes. So, and we've been off and running. But I think that, when I pick a nurse practitioner, it's going to need to be the same thing. It's got to be somebody who really cares about people and cares about relationships.
Absolutely. And I love that you're thinking about future growth. Now, I want to ask, had you entertained the idea of hiring or bringing on another physician versus a nurse practitioner?
Hell if I know. I mean, I have a really good business consultant that was actually really important in the development of my model too, because I had no idea what I was doing. I had been raised in captivity, all my life. I mean, I was trained in academics and then I went straight into private practice and I never had to think about the business of things. So actually one of my patients has a master's in health administration and I took care of him and his wife and their daughter. And, he had become a friend. And I called him when this all happened and said, what do I do? And so we have been exploring it together. So I pay him $1,000 a month and I have unlimited access to him. And so I have him look over contracts and his contacts have been important for just figuring out the landscape and how to work within it, all the insurance broker thing and all of that. So I don't know how I'm going to grow. I'm going to ask Cam to help me figure out. And the reason that I think a nurse practitioner rather than another doctor is because that seems more manageable to me. I can look at those numbers when I know that I've got a certain demand and I know what that demand will turn into financially. Then I can figure out if I can pay a nurse practitioner. And I also kind of feel like with a nurse practitioner, I can train them to be a mini me. I can have them shadow me around and see how I do medicine and how important a bedside manner is and how important the relationships are and mold them into the kind of person that I want taking care of my patients.
Absolutely. We've heard so many examples of how people who are in love with the model and what the model allows us to do, those people really adapt well to, how to do the model and how to finesse the model going forward. So totally hear you on that. Now, when it comes to paying Lacey, when it comes to paying this, potential future nurse practitioner, can you speak to how you opted out of insurances and how does that equal payment for yourself?
Sure. So I'm in a funny situation. So the whole first year of opening this practice, I have worked as a locums part-time. And that, was very lucrative and allowed me to build, I'll be honest, I take calls from my private practice phone, while I'm doing locums. And that's given me the freedom to pay my nurse very well. And that's really important. And I think when you're doing a small practice like this, it's like making cooking something very simple with just a few ingredients. Those few ingredients have to be really good, really quality ingredients. And so you have to pick the people around you really carefully. And so I pay Lacey very well. I got her from a hospital system where she was making $31 an hour. And I'd had a couple of glasses of wine too. And I said, I will pay you $33. And that's what I pay her. And she does everything. And she's responsible like that, so it was a good investment.
How do you go about paying yourself, especially because you're not accepting Medicare and other insurances? And then the other part was about like how you actively got out of insurances. Cause like, that's a question that other doctors will have, like, but you were you took insurance. How did you stop? How were you able to stop taking insurances? Did you have to like find those contracts and discontinue them? Like, how did you get out of, because you said you left quickly, like how did you get out of accepting any insurance?
That's a good question that I'm not sure I know the answer to. Again, I'm not the business mind here. I am still opted in with Medicare because I do locums, or I have been doing locums. And I had to make the decision recently whether to opt out or not. And, I've got like 30 Medicare people who they call me and they want me to take care of them. And I have to tell them I can't because you have Medicare. But I kept them all on a list. And I kept telling them, I think it's going to happen in February. I'm going to give up locums and I'm going to give up Medicare. And then I think it's going to happen in April. So my business consultant actually said, you know what? I'm telling you right now, you need to not listen to your big heart and you need to listen to your brain, and you should not be opting out of Medicare because that's going to limit your ability to do locums work and to take care of yourself and your family. So I made the hard decision to not opt out of Medicare. And what that means is that I can't see Medicare patients at all. I can't see them because you're not allowed to see Medicare patients if you offer a service that Medicare offers and not take their Medicare. And I don't want to deal with Medicare. I don't want to deal with any insurance company. So I just can't see them. And that's what I have to tell them. The business part of things is not that hard, actually, at least not the day to day. And my business consultant had me go through an exercise where I listed all of the costs per patient. So like I know how much the table paper per patient costs, and how much that patient's portion of the electric bill costs, because that's how I know what to bill and how I can be profitable. And so that morphs into, how much your overhead is per month. And once you clear that reliably, you can start paying yourself. And I have hit that point now. And, it costs so little. I think it cost me $5,000 to start my practice. So it wasn't a big hole that I was trying to dig out of. I rent space. I sublet space just 1 day a week, going to 2 days. So my overhead is really low. But anyway, so yeah, you figure that out. And once you start clearing that, you realize, okay, now I can leave the locums world and start paying myself. And that's just how you do it.
So valuable for people to hear. And can you give them a timeline as to how many months you're in practice? Because you just said you're starting to pay yourself. So how many months are you in with that as the case?
11 months.
Amazing. And I'm going to guess that people who, especially other gastroenterologists who might be listening, did not guess that as the right answer. So congratulations to you.
Thank you. And, I will tell you, if I had known what I was doing a little bit more, like if I had listened to a podcast like this and knew, okay, I need to get this contract in place and that one, and I need to be marketing myself to insurance brokers, I could have made more money faster. I've been figuring this. I'm the only one of me I know. I'm the only GI doctor that I didn't know anybody to ask questions. I had to figure it out.
And I will put here, because this is very important given what you just shared and what you shared earlier about brokers, is that especially if you are a doctor who is looking to, get your specialty care bundled into healthcare plans centered around direct primary care doctors who are looking to work with employers, I will put a shout out to the Health Rosetta Summit. The Health Rosetta Summit is going to be in Chicago, August 7th through 9th. And Health Rosetta Summit is where you will get an entire room of people who are looking to build direct primary care as a primary care model and as a business model with specialists into people's plans, small businesses, big businesses, national businesses. So it's definitely something to check out. That you can find that through the Health Rosetta website. I will be co-emceeing that conference this year again, and it is a place where last year I was like, where are all the doctors? We have so many brokers who are asking do you know a doctor in this area who does this? And the answer is yes, except they don't necessarily know who the doctors are. So in terms of people who are very much aware of DPC as a business model, how it pairs beautifully with many, many types of businesses, that's a great place to go and to network and potentially build your services into a healthcare plan. Now, I want to highlight the fact that you are creating this course that I already sent an email to my patient about last night. I said, hey, here's Dr. Scholl's website. Go and contact her. So the way that you describe your perfect week, your 3 days at the beach, and being able to make passive income with a course. Can you walk us through, how that all happened? And are you working with your business coach to develop this course as well?
No, this is my idea. And so the way that it came about is I do it, everybody's got their thing that they just really, really love. And I really, really love talking about the microbiome. And I can do it for hours. And if we went out for dinner, we would end up talking about microbiome one way or another. Bless your poor heart. I would make you listen to me. My kids just roll their eyes. Oh my God. This is your favorite word, Mom. But I found that I was in clinic and I was saying kind of the same things over and over and over because it is foundational. Feeding your microbiome is foundational to not just gut health, but whole body health. And people don't know it. And I feel like I need to tell them I'm serving them as their gastroenterologist best if I tell them at least a little something about it. So at the end of the day, I found I was exhausted because I've been saying the same thing over and over and over. And sometimes people are really fascinated and they want to hear more and they get on board. And other times their eyes just glaze over, and they really don't want to hear about it. And I thought, you know what? I could and I should scale this because I'm saying the same thing. I want to get all those people in the same room so I can just say it once. And then I want to harness the power of community because I'm asking people to make big changes. And if they can help each other and be accountable to each other and share wins and losses with each other, it's going to make them more likely to be successful. And the third thing is I only want to be in a room with people who are as excited about this and receptive to it as I am, And so that was the genesis of the online course. And it's a 3-month course and we cover everything. So it's the first course that I'm offering is specifically for IBS-D patients. And so these are people who are afraid of food or who have no idea what's triggering them. And I gave that social media and actually wrote a LinkedIn post too about how IBS is a bunch of BS because it is. IBS is just telling you have diarrhea. Thanks a lot. Why? Why do you have? And we used to just shake our heads and say, but we do know. My list keeps getting longer, but there are about 10 to 12 things that cause IBS. And now in my practice or in my course, I have the time to walk through that. And so anyway, in my course, it's divided into thirds. And the first month is talking about IBS, what it is, and how to check and make sure that you've had a good workup for it. Look back through your medical records or go and ask your doctor to test you for this. And let's figure out why you're having symptoms. And then the second part is teaching about the microbiome and how to build it. How to kind of rewild yourself because we've all, especially with the pandemic, we've all been trying to get cleaner and avoid germs. And that's the opposite of what we really should be doing. We should be trying to eat clean, but we should be living dirty and trying to get those organisms into our bodies so that they can do the heavy lifting of really creating health for us while we're not even aware of it. And then the third part is kind of putting that into action. So how do you do that on a daily basis? And sometimes, people need to be taught how to cook a little bit. They need to be encouraged to how to build more plants and fiber into their diet through things like compound foods like granola that have extra things like chia seeds and pepitas in it that you don't get in a regular recipe, or, smoothie bowls, or, grain salads and things like that. So.
And let me ask you here, because on your website, on the footer, it notes that you are the Plant Fed Gut Masterclass certified. So did you have that certification before you opened your practice, and has that drawn people to your practice?
I don't know if it's drawn people to my practice. I feel like if people are also aware of Will Bulsiewicz's work, then they're going to be looking for someone who shares the same philosophy locally. And so that's why I put it on my website. But it is, one of the things about direct care is that I now have work-life balance. And where before I got off work and I didn't want to think about work, now I do. I mean, I love medicine. That's why I got into it. So I got curious about the microbiome, and Will Bulsiewicz is a guy who trained at UNC as I did. And he wrote a book called Fiber Fueled, and it's all about using fiber to harness the power of the microbiome. And it passes the science test. It's not like a pop science, book. It is very evidence-based. And I had the luxury of time to take that class. And so that is something, and so I just followed my interests, my medical scientific interests, and I got Masterclass certified, and I'm able to share that with patients.
I love it. And to me, when I saw it, to me, it highlighted that this isn't like you're just, blogging about the microbiome. You're like actively doing things so that you're prepared with other information and other examples. And, in addition to your training as a gastroenterologist. And I love that as you develop this course and have it available, that as people find you, it's another way for people to learn about you and learn about what you do and how you approach things. And then for me, I could also see that making it easy for people to become your patients and talk about you. I know that was your GI experience. Let me tell you about Dr. Scholl and my GI experience, because she's my doctor. So I think it really does play so well into a business plan to highlight you as an individual and all the things you're interested in. And having a course, I think, is so awesome, because it even goes beyond that hour visit that you have with your patients. So I think that's so cool.
Yeah. And I kind of enjoy, and this is part of direct care as well. I feel like somehow I have more permission to be myself and to bring my authentic self into my practice. And so like on my social media, I have dogs and I have chickens in my backyard and I have a garden, and I show people that, and they seem to like it. I do try to bring more of myself so that they do know. And it's just a less clinical, less sterile experience. I hope. I am going for that. I want that. And I find that people respond. They want to know their doctor. They want to know you're a person.
I totally agree. And I love using the term, the non-doctor's doctor's office, because when people talk about like the waiting room that's not actually used for waiting, it's for getting coffee, or, the waiting room is actually, super luxurious, like it came out of, some kind of HGTV episode. It's not a typical, these are the chairs that you can wipe down easily with the Stanny wipe and not destroy them. So love it. So when we talk about you bringing you and all of your loves, your academia of patient care to your practice, something else that I want to highlight that is also highlighted on your website is your work with AI and gastroenterology. And so when it comes to the idea of practicing autonomously and being able to choose the tech and the tools that you have in your practice, can you share about your work with AI and how you were featured on the Samsung Verizon collaboration?
Yeah, that was really cool. I had the opportunity to work with these really smart Silicon Valley guys who were developing technology that would allow me to wear a mic and talk to a computer that they program, that they devise, to teach it to find polyps and to dictate my procedure note when I'm done. So gastroenterologists know that whether you use Provation or Endosoft, there's a template, macro, and you just click through it. And so we were developing a project or a software product that would allow me to just dictate that in real time. It's pretty cool. It's pretty slick. And out of that project, because they had a monitor beside me that I was watching in addition to my monitor, and it was a few milliseconds behind. And I kept telling them, you have got to speed it up. I can't look at two screens if they don't match exactly. It's way too distracting. So they developed this technology where instead of going like to some cloud in Atlanta or someplace, they just pinged right off the server in our endoscopy suite. And it got super fast. And that has turned into the Edge, Verizon's 5G Edge network, which is where the internet information, instead of, again, going to a cloud, it goes to a cell tower and back. So it's being used for autonomous driving and super fast gaming and things like that. So it's pretty cool. Enjoyed that.
It was so incredible. And if you have not watched it, I definitely would say watch it. There's a link to the YouTube video specifically in your blog accompanying this podcast. But, just the idea of what is out there, we as direct primary care, direct specialty care doctors can really harness things quickly, and we can pivot to incorporate those pieces of tech into our practices because it helps us do our job, differently, better, whatever term you want to use. I think about in rural America, where I trained in rural Nebraska, they have a camera that is in the ER so that if something happens where they need, support from a doctor who's not a family medicine physician from, Lincoln or Omaha or elsewhere, that they can have a doctor, visually be there. And so I think that especially how you were talking about in the video, if there's a tough case where you're like, I would appreciate another set of eyes to do the best work for this patient, that's a thing. That's really a thing out there. So, think about what your needs are. As my encouragement to the audience is to think about what your needs are as a doctor, and is there a tech out there that allows you to do that thing that you want to do? So I definitely would encourage everyone to watch that video. It's super, super cool. So as you have shared your story and you've reflected on how you were practicing and how you're practicing now, what would you say to other gastroenterologists specifically, or future gastroenterologists who are thinking about direct specialty care in the future?
Oh, I wish I had done it straight out of medical school. It's so much better. I can't even tell you. I mean, quality of life, career enjoyment, gratification. I don't know. It's just that every day feels like a job well done. And there are less headaches. It's all around better. You're giving better care. Patients are happier. You're happier. And you can make a living at it. You totally can. And I don't know if you will agree with this, but I tend to think that DPC docs are a little bit rebellious. And there's something that just feels really good about disrupting the system and just kind of telling, the insurance companies, no, I'm not going to play that way. I refuse. It feels really good.
Amen. I mean, we're standing up, like I'm totally on board with you. We're standing up for what's right. I literally told someone, people like you and I, we were not allowed to vote at one point in time, and that was wrong. And so now we are. And so, there's things in this world that are, I think of Harry Potter and Star Wars. Why are we so attracted to those? Because it's good against evil. And when it comes to the patient who can't get in, I mean, when you're talking 8 weeks in your area, sister, it's 8 months in my area. So when it comes to lack of access to care that is completely unacceptable for everyday Americans, I mean, there's people in other countries who do care differently, but as we have seen, other countries are now taking the fee-for-service system and building it into their systems. And we are showing by the bankruptcy rates that we see due to healthcare bankruptcy, the burnout of physicians, people, hating medicine and leaving, and us as doctors losing those skills so future physicians can't train with them. There's so many downsides to insurance-based medicine, and we are providing a solution, yourself as a specialist, myself as a primary care doctor, to give our patients the care that they deserve. So amen for being disruptors. I had to say this to a person that we're not disruptors violently, but we're disruptors innovatively. And so now that you have shared about your practice with other gastroenterologists and future gastroenterologists, do you have any dreams in particular about your practice or what gastroenterology looks like for you in the future?
Yeah, I do. Kind of part of my plan for world domination is I would like to own my own building. And I mean, that just makes good financial sense, but then have in it all the people that, you can refer to and who to create almost like a medical mall for patients so they can just go there and get what they need. So me, because I started it, primary care, obviously, an OBGYN, a psychiatrist or a psychologist, and maybe a dermatologist, I don't know, or a pediatrician. It could be a pediatrician now that I'm thinking about it. But you don't need that much space to be a DPC doc. I've got 1,000 square feet, but we only use 2 exam rooms and a workroom that's the size of an exam room. That's all we need. So you need like little micro offices. That's one of the challenges when you're starting direct care practice is where to put your practice. You don't need that much. So yeah, that's when I'd like to make it easier for people coming behind me.
That is such an awesome and achievable goal. So thank you so much, Dr. Scholl, for joining us today and being a fellow disruptor. Good luck on your and everyone's journey of world domination.
Thank you.
Next week, look forward to hearing from Dr. Nitin Gupta of Rivertowns Pediatrics in Dobbs Ferry, New York. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.